presenting a case of 25-year-old female with acid ingestion 6 months back. She came to me with abject feeding jejunostomy and tracheostomy in situ. There is complete obstruction at cricopharyngeal level on flexible endoscopy, and there is no passage for contrast to go beyond this cricopharynx. So there is complete cricopharyngeal stricture secondary to corrosive injury. So no lumen at all. Management challenges are dense and fibrotic veins are there, poorly responsible to dilatation because there is no lumen. There is high risk of perforation is there. So endoscopic cricopharyngoplasty was planned under general anesthesia. After that, we plan colon interposition graft. So choice of surgery by laser, diathermy, radiofrequency, coblation. So Coblator is best in this case because it works as low temperature. It having minimal lateral thermal damage, safe in scarred and fibrotic tissue, less edema and postoperative fibrosis, and there is lower risk of perforation by this. Laser and diathermy causes deeper thermal injury, hence restenotic risk is higher, and lateral damage is also higher than the coblation. After doing laser cricopharyngoplasty, you can see there is multiple granulation tissue inside the trachea just above the tracheostomy. So I also remove these granulation tissue from the trachea so that I can see tracheostomy tube clearly. So this case is very difficult, and this is done under general anesthesia by endoscopic exposure, identification of fibrotic cricopharyngeal segment. Coblator used to perform controlled midline cricopharyngotomy. After that, gradual widening of lumen under vision and hemostasis achieved by Coblator vent. And there is no mucosal tearing or perforation is there. Post-acid cricopharyngeal stricture require precision surgery. Coblation is the preferred tool due to minimal thermal damage. Avoid aggressive dissection. Long-term follow-up is essential due to recurrence risk. Corrosive acid ingestion causes severe mucosal injury to upper aerodigestive tract. Healing occurs by fibrosis and cicatrization, often leading to pharyngo-esophageal cricopharyngeal stricture. These strictures lead to complete dysphagia, aspiration risk, nutritional deficiency, and management is very challenging because of dense fibrosis, altered anatomy, and risk of perforation is always there. So, coblation-assisted cricopharyngoplasty is safe, effective tissue-preserving technique for post-corrosive cricopharyngeal stricture, especially these young patients may having normal life if we plan properly and follow up properly so that these type of cases will survive longer and having better life. After this, surgical reconstruction options are: first is colon interposition, colopharyngoplasty or coloesophagoplasty. It is preferred for long segment more than 5 centimeter stricture is there. Can use right or left colon, root either retroexternally or posterior-mediastinally. Advantage: it is reliable and having good length, good lumen size and resistant to reflex. Disadvantage: having two field surgery, neck as well as abdomen. Possibly redundancy is there or ischemia chances are there. Second surgery is gastric pull-up. Gastric transposition, whole stomach is mobilized and brought up to the pharynx. Third one is free jejunal transfer, that is microvascular surgery. Fourth one is tube radial forearm free flap or anterolateral thigh flap surgery. And fifth is pectoralis major myocutaneous flap or deltopectoral flap surgery. These are the five options you can choose according to length and lumen of the esophagus. And you can combine these procedure. So complete block 7 to 8 centimeter involving pharynx and cervical esophagus. Typical surgery having feeding gastrostomy, colon or gastric conduit reconstruction, pharyngocolic or pharyngogastric anastomosis at neck level, and laryngotracheal separation may be considered if there is risk of aspiration is there.